John here from bootcamp.com. Welcome to another video. In today's lesson, we're going to be taking a look at some of the descending motor pathways which we've been building towards. We're going to be looking at specifically the pyramidal tracts. And there are two types of pyramidal tracts. We have our corticospinal as well as our corticobulbar. Now the corticospinal, these are divided into anterior and lateral corticospinal tracts. And the corticobulbar, these have individual tracts for each cranial nerve nucleus, which we'll look at. So if you want to pause and take a look at the outline, you can do so, but let's just get started. Now, before we talk about the individual pathways, let's talk about the functions. So the lateral corticospinal tract, this is going to be involved in controlling the muscles that are responsible for precise and highly skilled movements, specifically in the hands and feet. So these are going to be found innervating those muscles in the forearm, which are controlling the hands, as well as those muscles in the leg, which are controlling the feet. Now, an example of when a highly skilled movement would be performed is if you were playing something like piano. This takes high precision in finger movements. You're moving a lot of different fingers at once, and the lateral corticospinal tract is going to be responsible for allowing you to make those movements so precise and highly skilled. So that's lateral corticospinal. Now the anterior corticospinal, this is involved in controlling the muscles of the neck, trunk, and proximal limb. Now these are going to be involved in more gross movements. Let's say I'm turning my trunk, twisting my trunk, or let's say I'm extending or flexing my knee. These are activating large muscle groups and performing more gross movements, not highly refined motor movements. Now, what you'll see is the corticospinal tract is actually going to descend, and it divides at a certain point known as the pyramid or the medullary pyramid. And at this point, 90% of those fibers are going to go into the lateral corticospinal tract, and only 10% are going to go into the anterior corticospinal tract. If you think about it, we need to have more motor neurons controlling more lower motor neurons to perform those highly precise movements in the fingers and feet, whereas you don't need as many upper motor neurons and lower motor neurons to perform gross general movements. So going back, let's take a look at the actual pathway for the lateral corticospinal tract. So starting off in the primary motor cortex, let's say we have an upper motor neuron, which is going to be controlling the hands. This is going to descend down through that corona radiata in the internal capsule. It's going to pass through the cerebral peduncles down, and then at this point of the medulla, this is where it's going to decussate at that medullary pyramid. So it's going to pass backwards and decussate, and it's going to continue to descend down our lateral corticospinal tract, which, if you remember, is going to be that tract or that area just lateral in that lateral column. So it's going to continue to descend. And then once it reaches that target spinal level, it's going to synapse with a lower motor neuron found in the ventral horn. And then that lower motor neuron, of course, is going to exit and go and stimulate that specific muscle. So next up, we have our anterior corticospinal tract, and this also begins in that primary motor cortex. It's going to descend down the corona radiata internal capsule, passes through those cerebral peduncles, continues, and then at the point of the medulla, it's not going to decussate. It's going to continue down in this anterior corticospinal tract right here. So it continues down, and then once it reaches its level, then it decussates and goes to the ventral horn, where it's going to synapse on that lower motor neuron, and then that lower motor neuron leaves through that ventral root and goes and innervates those muscles. So let's draw that out. So remember that anterior corticospinal tract is found on that anterior medial aspect, or the anterior white matter column. So this is the anterior corticospinal, and this is the lateral corticospinal. So you can see they both decussate. It just depends on the point of decussation. Lateral corticospinal decussates at the medulla and the medullary pyramids, and the anterior corticospinal tract will actually decussate at the level at the spinal level for which it's stimulating that lower motor neuron. So what would happen if we had a lower motor neuron or upper motor neuron lesion in one of these pathways? Well, if we have a lower motor neuron lesion, then we're going to see ipsilateral effects. And that is because, let's say we're destroying this neuron right here, because this lower motor neuron lesion is already on the side for which it's going to stimulate the muscle, you're going to see it on the same side, the ipsilateral side. However, when we take a look at the corticobulbar tract, you'll see that this is not always the case when we have a lower motor neuron lesion. Now, if we have a upper motor neuron lesion, we can see both ipsilateral or contralateral effects, and this really depends on the point of the lesion or the level of the lesion with respect to the point of decussation of each spinal pathway. So let's say we have a lesion up here. What are we going to see? Well, we're going to see contralateral effects because this neuron is going to come down and then it decussates or crosses over to the other side and it innervates the lower motor neuron on the contralateral side. Whereas if we had the same upper motor neuron lesion, but we had it somewhere right here, then you're going to see ipsilateral effects because it's already past that point of decussation. So we're going to see a loss of motor movement on that same side. When we're talking about the anterior corticospinal tract, it's kind of weird because the pathway stays ipsilaterally the entire time and then it crosses over. So the majority of effects that you'll see with regards to the anterior corticospinal pathway, these are going to be contralateral because we always have the point of decussation at the level of the spinal cord. So anywhere throughout the pathway, you're going to see that this is going to have a contralateral effect if we damage it up here. The only way we'd see an ipsilateral effect is if we damaged it somewhere down here near that point of decussation. All right, now let's take a look at the corticobulbar pathways. Now, there's many of them, but they all sort of have a similar pathway at the beginning. So they all originate in the primary motor cortex, pass through the corona radiata and internal capsule. Then at the crus cerebri, this is where they're going to either remain ipsilaterally or decussate to innervate their lower motor neuron motor nuclei. And then after that, of course, that lower motor neuron will go and innervate the skeletal muscle, and it travels through the cranial nerve in this case, and not a peripheral nerve like you'd see in the rest of the body. And I mentioned that some of the corticobulbar upper motor neuron will decussate and some won't. These usually, if they do decussate, they'll decussate at the level of the lower motor neuron. So it doesn't decussate at a higher point, it goes to its target and then it decussates and innervates that target nucleus. Now, out of all the cranial nerve nuclei, we have some that are directly innervated by the corticobulbar tract and some that are indirectly innervated by the corticobulbar tract. These ones are the ones that are directly innervated, and we're going to expound upon these in the coming slides, whereas the oculomotor, trochlear, and abducens, these are indirectly related. And if you know the function of these are all involved in eye movements, which has a special process involved with it. So let's start off first by looking at the trigeminal nerve and the motor input to the trigeminal nerve. Now you're probably saying, oh, the trigeminal nerve does facial sensation, but it also does the motor to the muscles of mastication, and that's what this corticobulbar pathway targets. Now, a way to remember that the corticobulbar pathway is targeting facial nerve nuclei. So for this pathway, the upper motor neurons, these are going to originate in that facial region of the primary motor cortex. And if you remember your somatotopic organization of the primary motor cortex, the facial area is going to be found somewhere around here. So these are going to come down and these are going to bilaterally innervate the lower motor neurons. So when we draw that out, it's going to look something like this. And it targets the masticator motor nucleus, which is found right here. This is going to be the lower motor neuron, and this is found in the pons, and this controls the muscles of mastication. So the upper motor neuron stimulates the lower motor neuron, which then leaves through the motor division of the trigeminal nerve and goes to those muscles of mastication. Now, how can we test whether we have a lesion in the trigeminal motor pathway? Well, we can perform a function test where we ask the patient to protrude their jaw. So stick their jaw anteriorly, and if you see weakness on either side, that means that there's some sort of lesion. But where might the lesion be located? If we had an upper motor neuron lesion, a lesion right around here, remember, because this bilaterally innervates, we're still going to have the other side coming down and bilaterally innervating those two lower motor neurons. So essentially, you could have a lesion but not see any effects. So in case of an upper motor neuron lesion, you might not see any effects. Whereas if we had a lower motor neuron lesion, what you're going to see is ipsilateral weakness to those muscles of mastication when you ask the patient to protrude their jaw. So one side will protrude, the other side will have difficulties protruding, and that indicates that the lesion is a lower motor neuron lesion. It's on the ipsilateral side. So now let's take a look at the facial nerve pathway. And as you'll see, this one is very unique in its own sense. Starting off first, the upper motor neuron, it's going to come from that facial region of the primary motor cortex. It's going to come down. When it reaches the facial nerve nuclei, it's going to both bilaterally innervate it as well as unilaterally innervate it. And I'll show you what I mean by drawing this out. So when we take a closer look at this pathway, you can see when it reaches the level of the facial nucleus, what it's going to do is it's going to give off bilateral innervations to each facial nuclei, right here and right here, as well as a unilateral contralateral innervation. And this is because the facial nerve nucleus is divided into two halves. We have a rostral half and a caudal half, and these are going to provide innervation to different parts of the face. So the rostral halves, these are going to receive innervation from both facial nerves, but the caudal half receives innervation from the contralateral upper motor neuron facial nerve. So like we mentioned, our lower motor neurons are found in the facial nucleus, and these are going to control ipsilateral muscles of facial expression. Now, like I mentioned, we have our rostral subnucleus and our caudal subnucleus. We looked at them in more detail here and here. Rostral subnucleus, bilaterally innervated by those upper motor neurons. Now what this does, this is going to provide motor innervation to the frontalis muscle, whereas the caudal subnucleus, this provides motor innervation to the lower facial muscle. So let's draw that in. So now you can see how this corticobulbar pathway is organized. We have the upper motor neuron coming down, providing bilateral innervation to the rostral subnucleus and unilateral innervation to the contralateral caudal subnucleus. These lower motor nuclei are then going to go on to innervate the forehead and the lower facial muscles. So that rostral subnucleus innervates the forehead, the caudal subnucleus innervates the lower facial muscles surrounding the mouth. Now, if we want to test whether these pathways are intact, what we can do is we can ask the patient to raise their eyebrows or to show their teeth. So if there was any damage along the pathway, we would be looking for if they have a deficit to be able to show their teeth, or if they have a deficit to be able to raise their eyebrows. And we'll look at those in a little bit more detail. So if we have an upper motor neuron lesion, let's say we have it right here, what sort of effects will that have? Well, this is coming from the left side. Remember, we still have all that innervation coming from the right side. So let's draw this in. So you can see with this upper motor neuron completely wiped out, we still have the opposite upper motor neuron providing bilateral innervation to the rostral subnuclei. So both of these subnuclei are still receiving input. So they're both still stimulating the frontalis muscle. So the patient should still be able to raise their eyebrows as if normal. What we would see deficits in is the contralateral lower facial muscles. And that's because if we knock out this pathway, we're no longer receiving that contralateral innervation of the caudal subnucleus. So this subnucleus is no longer going to be stimulated, and therefore these facial muscles will no longer be able to become activated. So what you're going to see is you're going to see facial droop. So all the muscles will be relaxed and the corner of the mouth will droop down this way. So the patient will still be able to smile on their ipsilateral side, but on the contralateral side of the upper motor neuron lesion, that's where you're going to see those facial deficits. Now, what's going to happen if we have a lower motor neuron lesion? Let's say we wipe out this entire facial nerve nuclei. This is going to have ipsilateral effects, because remember, these cranial nerve nuclei are going to be on the ipsilateral or same side as their cranial nerves which come out. So we're no longer going to receive stimulation to the frontalis muscle via that rostral subnucleus. We're no longer going to receive stimulation to the lower facial muscles via that caudal subnucleus. So what you're going to see is complete facial droop. So the patient will not be able to elevate their eyebrows on the ipsilateral side of the lesion, and they will also not be able to elevate or show their teeth on that ipsilateral side as well. So what you're going to see is, if we divide the face down the middle, the entire affected side, this is going to be drooped downwards, or it's going to be depressed. And that's because this is going to have ipsilateral effects. Now, how can we distinguish the effects between an upper motor neuron lesion or a lower motor neuron lesion, or Bell's palsy? Well, like we mentioned, if you have an upper motor neuron lesion, you're still receiving bilateral innervation to that rostral subnucleus. So you're still getting bilateral stimulation of the frontalis muscles. So the forehead and eyebrows will be unaffected, whereas the contralateral lower facial muscles, those will be affected. If we have Bell's palsy or a lower motor neuron lesion, you're going to see complete paralysis on the ipsilateral side of that lesion. All right, so next up, we're going to take a look at the nucleus ambiguus pathway. And this receives bilateral innervation, just like we saw from the trigeminal nerve motor nucleus. So this is going to be controlling basically the glossopharyngeal nerve and the vagus nerve. So the upper motor neurons originate from that primary motor cortex, and they come down and they bilaterally innervate the lower motor neurons. So the lower motor neurons are going to be found in the nucleus ambiguus cranial nerve nucleus, and these are going to control ipsilateral muscles of the soft palate, larynx, and pharynx. And if you know, these muscles are controlled by the glossopharyngeal nerve as well as the vagus nerve. So let's draw this pathway out. So you can see we're going to have our upper motor neuron. It's going to descend down, and when it reaches the level of the nucleus ambiguus, it's going to split, and it's going to provide bilateral innervation to each nuclei. And this is both coming from the left cortex as well as the right cortex upper motor neurons. So both of these cranial nerve nuclei will receive input from both of the upper motor neurons. So one way that we can test for this pathway is to test the patient's gag reflex, speech, or have them say ah. And let's look at what happens if we have an upper motor neuron lesion. Well, if we have an upper motor neuron lesion, let's say we have damage right here. Remember, we still have the upper motor neuron from the opposite side, which is going to come down and provide bilateral innervation. So it's going to mask the effect. So you're not going to really see any presentation in that sense. However, if we have a lower motor neuron lesion, if we damage this cranial nerve nucleus, then we're going to see ipsilateral effects, because remember, this is going to be on the same side of the muscles that it's going to be innervating. So we're going to see ipsilateral effects if we have a lower motor neuron lesion. So next up, we're going to take a look at the hypoglossal nerve pathway. And this one is also unique in the sense that it contralaterally innervates the lower motor nucleus. So the upper motor neurons originate from the facial region of that primary motor cortex. They'll come down and then they'll decussate and innervate the contralateral lower motor neurons. So lower motor neurons, these are going to be found in the hypoglossal nerve nucleus. And if you remember, these are going to control the genioglossus muscle. This is the muscle which allows you to protrude the tongue out of the mouth. So a function test that you would perform is have the patient stick the tongue out of their mouth. So let me draw out the pathway and then we can walk through it together. So we have our upper motor neuron coming down our pathway, and then once it reaches the level of the hypoglossal nerve nucleus, it's going to cross over and it's going to innervate the contralateral lower motor neuron. This lower motor neuron is then going to go and innervate the ipsilateral genioglossus muscle. So what happens when we have damage to this pathway? Let's say we have an upper motor neuron lesion here. Well, the contralateral side of the tongue is going to be damaged. So when you ask the patient to protrude their tongue, the tongue is going to deviate to the side of the weakened muscle, which is going to be contralateral to where our upper motor neuron lesion would be. So if we have an upper motor neuron lesion, we're going to see contralateral tongue deviation. Whereas if we have a lower motor neuron lesion, we're going to see ipsilateral tongue deviation. So this muscle would still be intact. When the patient protrudes their tongue, the tongue will deviate to the side of the weakened muscle. So if it's a lower motor neuron lesion, it's going to be ipsilateral. And if it's an upper motor neuron lesion up here, it's going to be contralateral. And when you're learning this material, it's important to walk through each of these pathways and draw where you think a lesion may arise, and then determine what downstream effects you would see. That's the most likely the way that you're going to be tested, and that's the best way to problem solve and understand how these pathways work. So with that said, hope you enjoyed that, and I'll see you all in the next one.